Hello, everybody. Good afternoon. Um, Welcome to the Michigan Center for Rural Health Infectious Disease Echo. My name is Renee Hawkins, and I have the privilege to moderate today's session. Today's session is on therapeutic management of non-hospitalized adults with COVID-19. Just a couple of housekeeping announcements, For a more collegial environment, we use first names only. Please be conscious of confidential, protected health information. Raise your hand if you have a desire to speak. Please keep your microphone on mute until you're ready to speak. And then before you speak, please say your name and where you're from so we know who we're talking to. The presentation will be available following this session, and I will give you a follow-up email in regards to submitting for your CME credits. And then obviously, if you can, always in your either registration or in our case form on our website, please submit a case. And with that, I'd like to welcome Dr. Gulick, Peter, and he will be presenting today and going over a couple cases. Thanks for being here.
No, thanks for inviting me again. So what we'll do is, again, talk about therapeutic management of non-hospitalized adults with COVID-19. And the reason being is that there's always a lot of questions about, primary care doctors and what they can do as far as managing COVID-19, especially now. Besides using the vaccines, is there other treatments that could be done? And so what I wanted to do is kind of review that with you, considering the new variants that are out there, and put everything into perspective as of February 15th. Next slide. So I have nothing to disclose. Next slide. And these are the objectives: to discuss high-risk groups and how they should be considered for therapeutic management of COVID-19, meaning, do you have a certain patient that'll come to your office and say, oh, I've been exposed to COVID, or I've just tested positive, or I may have symptoms, and how do you evaluate whether they require medication or not? And then to discuss what the therapies are, both the antiviral therapies, and then to give you an update on the monoclonal antibodies, all for non-hospitalized patients. And then to discuss a little bit about the use of convalescent plasma, since that's been looked at and talked about. And then finally, a little bit about pre-exposure prophylaxis with monoclonals, given the fact that some individuals are at high risk for getting COVID, and would they be better off getting it to protect them rather than waiting till they get the infection. Next slide. So what agents are approved? So we're going to go over all these. There's 3 antiviral agents we'll talk about: Paxlovid, Remdesivir, and Molnupiravir. And then we'll talk about the monoclonal antibodies briefly, and then when and how do you administer them? And we'll talk about the test and treat concept, as well as infusion centers, since Remdesivir is only given intravenously at this point, and then who should be treated. And some of the criteria about who should be treated, you should think about individuals that are at high risk for COVID complications, older than 65, have a high BMI, have comorbid diseases is listed there, or just immunocompromised.
Earbuds in so you don't have to listen.
HIV or AIDS patients, people that are being given high dose steroids for long periods of time, those kind of individuals, risk for contracting serious COVID. Next slide. Next slide, please. Yeah, perfect. So these are the agents. These are the ones that are available currently. And again, I'm giving you up-to-date information. So the Paxlovid is still the agent that's probably utilized the most because of the fact that it's oral and it can be given, rather easily, usually within 5 days after symptoms. It does have a lot of drug-drug interaction because of the fact that it has this booster called ritonavir, which I'm well aware of, given it in HIV patients for a year. But ritonavir can alter the levels of other drugs and cause sometimes side effects to that. We'll talk a little bit more about that. Remdesivir, which is currently only IV, but the good news is they're doing studies as we speak on an oral remdesivir, which will be a game changer. And then molnupiravir, which is more or less an alternative because it doesn't give you as good a response. The monoclonal antibodies is where things have really changed dramatically, and where in the past we were using sotrovimab for the different species or variants of COVID-19, including the early on the Omicron, but the newer strains of Omicron, the newer variants are no longer effective. So this is not a drug you want to use anymore. It's not effective in many areas you can't even get it. And the same thing goes for Evusheld, which is the agent you use for pre-exposure. So you had a patient that's high risk that goes to get, that wants to go somewhere, and he may have gotten vaccines, but never got a response because his immune system's so low. This is another drug, unfortunately, not effective anymore. Systemic steroids. Again, the biggest impulse to do is when you have a patient come into your office and they're coughing and congested and everything, is give them a dose of steroids to reduce the inflammation. It's really, really not indicated in patients that have early COVID, because the virus will explode and proliferate even faster. And this is both for inhaling steroids as well as systemic steroids. And then the monoclonal antibody that was found to be most effective for the new variants, bebtelovimab, which were effective against the earlier strains of Omicron, are not effective against the new Omicron variant. So these are major changes that everybody should be aware of. So to summarize that, basically, there is no monoclonal antibody that you can utilize anymore to treat COVID-19 as an outpatient. So until new ones come about, you're restricted to the antivirals. Next slide. So how do we prioritize the use? Do we treat every person that has COVID-19 that comes to your office with Paxlovid or with remdesivir? So these are different tiers where you would definitely consider treating. And tier 1 is the highest risk group. These are immunocompromised individuals that still can't mount a response to the vaccine despite vaccine doses. And usually the kind of patient that this would fit the criteria would be somebody that's on high dose chemo, a bone marrow transplant recently done, an AIDS patient. These are the individuals that would have that kind of a situation where a lot of times the CDC says that not only do you give 2 doses of the primary, meaning a dose a month apart, but when you go to the boosters, or not boosters, but with immunocompromised like this, you'd actually give 3 or 4 doses, not just 2 for primary, but 3 to 4. So again, these are real high risk individuals. Unvaccinated individuals, because of the fact that, again, and the ones that are at highest risk are the ones that are older, or that are older and have additional risk factors like diabetes, hypertension, obesity. So those are tier 1. Tier 2 are individuals that, again, are unvaccinated, and they can be either greater than 65 or less than 65, but they have risk factors. So they, again, are comorbid. They have comorbid diseases. They may be a diabetic. They may be having heart disease. They may have, just obesity. Those kind of individuals would fit tier 2, and again, would be ones that you want to consider. Next slide. Tier 3, again, we're getting into individuals now that are vaccinated. So they do have a vaccine, but then they have age-related issues, So greater than 75 or greater than 65 with risk factors, again, like the ones I mentioned, the comorbid conditions. Even a vaccinated individual may not mount as good of a response. And, these are ones that you might want to consider if they have, some serious, maybe not treated well comorbid diseases. And then vaccinated individuals who maybe got the primary vaccine, but then they didn't get any boosters, and especially the bivalent booster. So if you have a person that's had the primary vaccine but never got a booster, they at least need the bivalent now, because the bivalent vaccine booster is found to be much more effective than having monovalent, the older monovalent vaccines for developing a good response against the new Omicron variants out there. And then finally, tier 4 are, again, we're looking at very similar terminology here, just remembering age has a great deal to do with it, greater than 65, definitely greater than 75. But then even if you're less than 65, but you have comorbid diseases, those are at high risk, and those that have not got the booster. So those would be individuals that you would consider for getting the COVID vaccine, or not COVID vaccine, but for getting the treatments, the antiviral treatments. Next slide. So you really want to prioritize the use of anti-SARS-CoV-2 therapy. And again, just to re-emphasize the fact that these are individuals that definitely need treatment. There's no complication. I mean, even if they're asymptomatic or they have very minor symptoms, they need treatment because they can progress very quickly. Patients receiving this drug called Rituxan, and Rituxan or rituximab is used for more than just cancer. They're used for people that have a condition called idiopathic thrombocytopenic purpura. What it does is it destroys your B cells, which are responsible for making antibodies, and so they will reduce autoimmune complications. So they reduce the antibody production that destroys your platelets or red cells and that. So Rituxan is used for a lot of conditions, but anybody that is getting that drug needs to get, consider getting COVID or antivirals, because the B cells is what makes neutralizing antibodies. And if you're absent with those, that's a high risk. And then bone marrow transplants, like we talked about, or individuals that have lymphomas on therapy, or ones that have had a transplant within 1 year and they're on anti-rejection medicine. And then finally, untreated HIV or AIDS, which I have several patients on. These are the real high-risk people that you should not even hesitate in giving antiviral therapy to. Next slide. So looking at the antiviral therapies, again, and just to make a preference, or just a little bit of a note here, no matter what variant you have, we're getting variants by the minute. The XBB now is the most current variant we're talking about, and this has an effect on monoclonal antibodies, and it may have an effect on the vaccine response and different issues like that. One thing I can tell you with certainty is the antivirals are not affected by any of the variants, because the variants are basically changed because their spike protein changes, and that's what causes the variants to occur. And those may have an effect on the vaccine or may have an effect on monoclonal antibodies, but the antivirals work in a different area of the virus. So for instance, Paxlovid works on the protease inhibitor. It's inhibits viral protease, which has nothing to do with the variants. The variants all have the same protease. So it's effective against all variants. It has to be used within 5 days of symptoms. So if a patient comes in and they're already 10 days out, or, over 7 days out, then it's more likely the, horses out of the barn. So it may not be effective, but 5 days has been found to be where it's most clinically effective. The dose is twice a day for 5 days. And you can see the adjustments for renal failure, and avoided if the patient has decompensated cirrhosis, which would be Child-Pugh class C. And then finally, the big issue with Paxlovid is the drug-drug interaction. So what you have to do is, if the patient's on several different drugs for high blood pressure, for lipids, for diabetes, et cetera, look up the drug interactions. There's a Liverpool drug interaction thing. There's several things that you can look up on your on Google for drug-drug interactions, and put in Paxlovid and then the drugs the patients are on to see if there's any drug-drug interaction, because that's the real key in using Paxlovid. You have to make sure they don't have that. And you can also use it in pregnancy at this point. Next slide. The clinical trials were great. You can see there were over 2,000 participants, and it showed that there was almost a 90% risk reduction in serious illness or hospitalization, meaning that the individuals that took this had a 90% chance of not going into the hospital and getting sicker with it. So it was definitely something that was very, very effective and useful. And that's why we look at it in people that are at high risk for going into the hospital and getting a serious illness. The side effects can cause some taste issues 6% of the time, and 3% of the time diarrhea. Next slide. Remdesivir is a IV drug, so it's not given orally. It actually, you probably remember, it was given in the hospital, still is, matter of fact, for people that are hospitalized with COVID-19, and it does reduce the viral load early in treatment. It doesn't have any effect once they get into the cytokine storm, but it's very effective early on. Well, they have also looked at it for short treatments, 3 days, in individuals as an outpatient, but it has to be given in an infusion center. It works again on the virus. It replicates, or it binds to viral RNA dependent to polymerase and inhibits viral replication. Again, effective against all variants. So Omicron, Delta, Omicron, subtype XBB or B1 or B2, any of them are effective. This one gives you a little bit more leeway in that you use it within 7 days of symptom onset with mild to moderate COVID-19. So individuals that come in maybe with a sore throat, maybe a headache, maybe a cough that's not serious, but their O2 sat is normal, and they've been exposed would be and especially if they're high risk, would be an individual that you could consider for this. If their GFR or renal function is less than 30 millimeters per minute, then you have to look at the risk versus benefit. They don't say don't use it, but they say you have to look at the risk versus benefit at that point. And they have used it in the hospital in people with renal insufficiency and not had any problems. The good thing about this drug is there's no drug-drug interaction. So if you have a patient on, a lipid inhibitor or a diabetic drug or a drug for heart disease, hypertension, whatever the drug is, there's no or very little drug-drug interaction. So it definitely has an advantage over Paxlovid in that manner. It can be used in pregnancy. And again, be aware of the fact that there's soon to be an oral version of the drug. They are right now doing studies at various clinics around the country looking at remdesivir as an oral agent. And then once it's released, I think it's going to have a definite effect on the use of Paxlovid because of the lack of drug-drug interactions. Next slide. The clinical trials are just as good as what we saw with Paxlovid. So in the Pine Tree study, they saw that there was a 87% risk reduction of serious hospitalizations and death versus placebo. So again, another very, very effective drug in preventing the infection from progressing on and getting into real trouble. And so this is, again, another very effective agent. And when the new oral agent comes out, it's going to really be utilized a lot, I have a feeling for. Adverse effects, occasionally it can cause liver enzyme elevation or creatinine increase because of the carrier, the vesicle where the drug is carried into, but nothing serious and nothing where it was noted as being a serious problem, but it's mentioned there just so you're aware of it. Nausea can be an effect, and then very rare cases of hypersensitivity. So if you do give it as an IV infusion outpatient, you just monitor the patients a half hour after they've gotten it or so to make sure they don't have any serious reactions, but it's not a very common thing at all. Next slide. The last antiviral is one made by Merck company. It's called molnupiravir. It's another drug that works on the RNA-dependent RNA polymerase, and again results in viral mutation. So the virus mutates as a result and becomes, and what happens is it can't survive when it mutates, so it's a lethal mutagenesis. So it causes the virus to actually destroy itself with these mutations. Again, effective against all COVID-19 variants. The fact that it does cause this effect on mutagenicity is always a worry, because could the virus mutate into a more resistant variant? And there's always that risk factor They haven't proven that, but that's something in the back of your mind you think about when, with this drug. You have to use it within 5 days of somebody developing symptoms, either mild or moderate. The thing, and then again, it's a therapy daily for 5 days. It's not indicated for pregnancy or for young children because of the fact of the mutagenic potential in animal models. And so you want to make sure they're not pregnant at the time you give them this drug, and then have them abstain from having any sex or contraception for 3 months after using molnupiravir, especially in males, so they can't, get the product into a female and then have this occur. So those are some of the restrictions, but even more so than that, next slide, please. When we look at the studies that were done, we see that the studies that reduced the rate of hospitalization and death was basically, it reduced it only by 30% compared to placebo. You remember Paxlovid was 89 and remdesivir was 87%. So this has a very low response, excuse me, as far as preventing hospitalization and death. So because of that, this has been put on the alternative list, so that if you were to look at the CDC and what they advise for for treatment of outpatients with COVID-19, they would list Paxlovid, they would list remdesivir, and as an alternative, say they can't take Paxlovid for whatever reason and they can't get an IV infusion with remdesivir, then you could use molnupiravir as a third option. Prior to the new variants, we used to use a lot of monoclonal antibodies too, but now we obviously can't. So this would be an alternative, not as a primary treatment. And you want to make sure you assess for pregnancy because of the mutagenic potential. And it's not authorized for children less than 18 years of age because of the potential complications that can occur with the bone and cartilage. And other than that, it can cause some nausea, diarrhea, dizziness. And again, fortunately, it doesn't have the drug-drug interactions, but it's not a drug that's being used that much, at least here, just because of the fact of the low response rate and then the side effects. Next slide. What about steroids? I mean, everybody likes to use steroids in respiratory infections. They come in, they have a cough, they're wheezing a little bit, so you give them their antibiotics, but you always want to give them steroids as well. Well, the CDC and the treatment guideline panels recommends against use of systemic steroids to treat outpatients with mild to moderate COVID because of the fact, think about it, where we're at in early stage diseases, viral proliferation.
I heard that, I'm like, no, then I saw it, I'm like, oh, thank God.
And by giving steroids, you're going to really reduce any immunity that does form, and then you're going to cause this virus to really accelerate. And there's been cases where the virus has actually gotten worse in people that were treated with steroids versus those that weren't. So steroids are not to be used, and that goes for inhalation or systemic. If there's a pre-existing problem, say they're on steroids because of an autoimmune disorder or because of some other disorder that they're on a daily dose, then you continue it, but monitor them very, very closely. And that would be another area where you definitely want to get them on an oral antiviral. The use of, there's no good trials, there's nothing to support using any of the drugs listed below. And I know there's a lot of controversy on the different drugs listed there, chloroquine, ivermectin, and different things like that. So just remember right now, the guidelines, the CDC does not recommend any of those for treatments. Next slide. So what about monoclonal antibodies? I got done mentioning that they're no longer useful, but I wanted to give you an overall view of how they work because there's going to be a new level or new range of monoclonal antibodies coming out in the near future. So I just wanted to kind of give you a background on this. So basically the SARS-CoV-2 genome encodes 4 major structural proteins. You can see them listed: the spike, envelope, membrane, and nucleocapsid. The spike protein is what attaches onto the ACE receptors and causes the virus to, kind of embed itself on the cell and then invade it. And so this is where the majority or all the monoclonal antibodies have been developed for. They target the spike protein specifically, both for post-exposure as well as pre-exposure. The problem is monoclonal antibodies, it's like a lock and key. The key only fits a certain lock. So they're very highly specific for attaching to these specific receptors on the COVID virus. So if the COVID virus mutates, which it does, like to give you an example, the Omicron variant has, the newest one now, has had over 30 new mutations in the spike protein area. So what this does is it negates the ability of the monoclonals to attach onto them anymore. That lock changed, so the key doesn't fit anymore. And it's more immunoevasive, meaning that the immune system doesn't recognize it. And even with the new vaccines out there. And so there's been a problem with some of these new variants that have been forming. Fortunately, we have enough immunity that the majority of us still have good immunity and prevent serious hospitalizations and deaths, but many of us get infected now with COVID-19. It's not a thing that prevents infection. The monoclonal antibodies can be used within 7 days. And again, none of the monoclonal antibodies are currently effective against the new Omicron variants. But what I can tell you is they're looking at a new generation. The new generation, they're going after that part of the spike protein that doesn't change, it doesn't mutate, and it's part of the spike area that just doesn't have any changes whatsoever. And so because of that, it doesn't have any effect on the virus mutating itself. So that's number one. Number two, they're looking at other monoclonal antibodies that may attach onto some other parts of the virus, maybe the envelope and membrane. So these are some of the new generation monoclonals that they're working on as we speak. So more to come on those, and I think we'll probably be seeing some new ones out in the near future. Next slide. And this just, again, gives you a good example. We're looking at, the different forms of the COVID, all the way from the first one, Alpha, then Beta, then Gamma, Delta. Now we're down to Omicron. And then we're looking at the different monoclonals all the way, up at the top list there, from BAM to ETE, all the way to, and they go from the first generation all the way to the third generation, going from left to right. But what you can see just by your eyes scrolling through there, the Alpha, Beta variants were, other than the first one, the BAM AET which wasn't very effective against any of the variants other than the Alpha Delta. The other ones were pretty active until we got to Omicron. And now with Omicron, even the SOT, such milibab, it's active, but there's a little asterisk there because you need higher doses against B1. And now the predominant strain where the XBB came from, the newest variant, is from the B2, so it has no activity. And you can see there that the Evusheld, which is used for prophylaxis, not effective against new variants, and the bebtelovimab, which is the newest monoclonal, which was effective even against the newer strains of Omicron, is no longer effective against the new variants. So I just wanted you to get this perspective about what's happened over time. Next slide. And you can see that the monoclonal antibodies, when they were given, you had to watch for hypersensitivity and different side effects. There were no drug-drug interactions. And, since it was an IgG product, they were considering it safe for pregnancy. So hopefully the new generation will have the same safety monitoring. And so they were pretty easy to give and not too bad as far as monitoring. You'd watch them for a half hour after you gave them to make sure they didn't get a sensitivity. And that was it. Next slide. They were usually effective for about 3 months. The Evusheld was effective for 6 months. So that's how long they would last. And this is the monoclonal antibody. Look here. As far as a summary goes, again, don't bother to get any of the monoclonal antibodies, even if you have access, because they're not effective. The XBB now is in the Northeast, it's like 80% of the strains. In the Midwest, I can't keep track of it, but we're getting more and more strains of that. And that strain is highly resistant against all monoclonals and even the vaccine to some degree. And so basically the bottom line is none of them are effective, including the one for pre-exposure prophylaxis. Next slide. And then the last monoclonal that was developed, bebtelovimab. Again, this was one that was used in high-risk individuals to reduce hospitalization. They had good data to support it. But again, with the new variants, it's not effective for Omicron subvariants BQ1, BQ1.1, and XBB. Next slide. The Evusheld, this was a good concept because it was used to individuals at high risk, either immunosuppression or unvaccinated. And then somebody that may have a high risk condition and may be going somewhere that might cause exposure. And so this would be something where you would these are not to be given as treatment for somebody that already has COVID, but more or less for prevention. But again, the bottom line is it's not utilized in subvariants. Next slide. Convalescent plasma. This is where we looked at individuals that had been exposed to COVID, taken their plasma, and looked at its effectiveness. And there's been a lot of debate about this, and it's hard to summarize these in many cases, but there's insufficient data for or against the use of this in both hospitalized as well as non-hospitalized patients with impaired immunity. And the only area where it might be useful, where they found it to be useful, was in individuals that had high titer antibodies. So in the hospital, especially if you had somebody that was going to be given this because of nothing else working, giving it with individuals so that the titers in the plasma was very high may have an effect. So again, this may have an effect on patients as outpatients. But again, this is nothing that's, we don't have a lot of clinical data to back up using these things. So I think my interpretation of this is just, it's not another combination you'd want to consider, at least at the present time. Next slide. So let's utilize what we heard into several cases so that I can show you how these cases would, how you would go about these cases. So let's look at case number one. This is a 68-year-old who calls your office because she recently tested herself for COVID and was found to be positive. Her symptoms included sore throat, headache, and fever, and she's only had them now for 3 days. So obviously she meets the 5-day criteria. She did a home O2 and it was 97%. So you remember the different stages of COVID, and it's asymptomatic, mildly symptomatic. And then when you get into the pulmonary phase where they have more coughing and that, then they do a blood or a FiO2. And if it's above 94, they're considered, you can still treat them outpatient. If they're less than 94%, then you want to maybe consider putting them in. But she meets the criteria of not having severe hypoxia. She does have comorbid conditions though. She's diabetic, she has hypertension, and her BMI is 30. So she's considered obese. She's on insulin and lisinopril, and she's been vaccinated with a booster. And it's important to know what booster, because since September of last year, the booster of choice is the bivalent. So you need to get the bivalent. And even people that have gotten infected in September need a bivalent vaccine to, even enhance their immunity even more. She now asks you if anything further should be done. So let's look at the choices here. So do supportive care only. I almost wish I had one of those buttons that I could have the audience respond. Maybe someday we'll do that and then see what everybody's feeling would be. But at this point, do supportive care only. Well, let's look at her. She's greater than 65 years of age, and she fits the criteria of having comorbid diseases. She's only had symptoms for 3 days. So she meets the criteria for putting her on an antiviral based on all those criteria there. And I think she would be, tier 2 or something, maybe possibly tier 3, but still she would meet the criteria of going on therapy, given her age, given her comorbid conditions, and given the fact she's only had the symptoms for 3 days. So A is knocked off. So now we go to number B, Paxlovid. Could we use Paxlovid? Well, She's within the time span, 5 days. Does she have drug-drug interactions? And that would be the next thing you'd want to look at. What drugs is she on? Is there an interaction with Paxlovid? And you'd look at it, lisinopril and insulin. And to my knowledge base, I don't think there's any drug-drug interactions that we have there. So that would be another reason. And so Paxlovid definitely would be a choice we could use in this individual, and giving it her twice a day for 5 days would be something recommended. How about number B, or C rather, remdesivir? Well, if she had a lot of drug-drug interactions and you're really concerned about her, this might be the alternative then, remdesivir. But remember, it's intravenous. She still meets the criteria, less than 7 days in this case, so she's 3 days. And she's high risk, but it has to be given at an infusion center daily for 3 days. Molnupiravir, you know, if for some reason she couldn't get to an infusion center and she's had numerous drug-drug interactions and you were still concerned about her, why not go for the 30%? I mean, she's not a high risk, she's not pregnant, she's not less than 18 years of age, and there's no drug-drug interactions with molnupiravir. Even though you only get 30%, go for it. You know, I mean, it would be up to you. Normally what would happen is when we had the monoclonal antibodies available, we would consider doing that rather than molnupiravir. We would go to a monoclonal antibody like bebtelovimab, but we don't have any available, so that is eliminated with the new variants now. And convalescent plasma, I told you before, basically doesn't have any data behind it, so you'd be on your own using that. So the correct answers would be B and C, B being number 1, C being number 2. And then I guess you could put D if the other 2 didn't respond. If there's any questions on these cases, just chat them in or whatever you want to do. Next case. This is a 40-year-old, but he has a history of non-Hodgkin's lymphoma and is getting Rituxan for lymphoma. Remember, Rituxan is used for lymphoma many times as an agent after you get the high-dose chemo. But remember, it's a B-cell destroying agent. It destroys B cells. It's very effective for lymphoma, but it can reduce your immunity, especially antibody production. He had COVID vaccines with 2 boosters because he was so immunosuppressed. Remember, I told you they have their primary vaccine and then they get not 1, but 2 because of the fact that, you know, and it's important to know, was the last booster bivalent? He states he was at work and was told that a coworker became positive for COVID. He tested himself at home and lo and behold, he's positive. But he only has nasal congestion and a scratchy throat, no symptoms of respiratory at all. He's also on prednisone because many times people that are on, you know, lymphoma patients get put on longer term steroids. And he calls you to ask you what to do. So here's a real interesting case. He's a young guy, young person. And, oh, you do have something here you can submit. Yeah, that's interesting. But yeah, you really, you know, you have a young individual. He has minimal symptoms, no respiratory, but he's high risk lymphoma on Rituxan and on prednisone. So do nothing but stay quarantined? No, not at all. Stop the steroids. Well, normally you don't want to use steroids when you have COVID because it'll accelerate. But in this case, he's on it for his lymphoma, so you can't stop it. That's going to have an effect on his lymphoma. So you have to keep it on. And that's even more reason to get him on some therapy. And Paxlovid, again, looking to see what drugs he's on to see if there's any drug-drug interactions. And if not, Paxlovid would be the agent. If Paxlovid can't be used, then remdesivir really should be considered in this case because he is a high risk. Even if it's IV infusion, he needs remdesivir. Molnupiravir, again, I would go with the IV remdesivir rather than, you know, because of the fact that molnupiravir is only 30%. This guy's at high risk. He's a tier 1. And monoclonals don't work in convalescent plasma in this case, unless he started to get real sick. Now, I know some clinicians, what they'll do is they may start on Paxlovid, but if this guy progresses, they may add remdesivir IV and may even consider using convalescent plasma because At this point, you want to throw the kitchen sink to prevent him from going into a COVID storm and getting real sick. So the correct answer here would be number C, and then D would be the second one. Next slide. Case number 3. This is a 55-year-old admitted to the hospital with progressive nausea, vomiting, diarrhea over 3 days. He has a low-grade fever. He has no other complaints, and his past medical history is hypertension, heart disease. He had a COVID vaccine and booster, and it's important to know, was it the bivalent? Because they're showing that the bivalent booster, when you compare it with monovalent, has a better response to the new Omicron variants, and you get a 59% response versus a lower response. So even though it's not a super high, it's still better. So make sure that they have the bivalent. Any individual like this prior individual should be vaccinated with the bivalent, and some may argue giving 2 bivalents a month apart to get him extra immunity because of the fact he can't respond. Not this gentleman, but the one in case number 2. So he is diagnosed with acute gastroenteritis. A COVID test was done and was positive. His FiO2 is 98%, chest x-ray is normal. He is put in isolation. What would you do now, especially if the concern was for the new Omicron XBB subvariant? And this is, again, a very important point to bring up because we have several factors here. Number one is COVID sometimes can present extrapulmonary. It may not present with pulmonary symptoms, very rare, but it can. And so, oh, I see that. Okay, so we have this was on case number 2. So actually, yeah, with case number 2, that was your gentleman with the lymphoma. You'd want to use the Paxlovid, though. People ignored that, maybe because they were worried about a drug-drug interaction. And if there was, then I would agree that remdesivir would be your next drug. But do not, and I stress, monoclonal antibodies are not effective in the new variants now. They are not. So the CDC and everybody says do not use them. You probably won't even be able to get them, but if you happen to, don't use them. So, I mean, Paxlovid and remdesivir, either one of those would be definitely the correct answer. So getting back to this case, he was isolated and, you know, you were concerned. So what do you do in this case? Well, what I was saying was that COVID can present gastrointestinally. It has a lot of ACE receptors there. So some people present with severe gastrointestinal symptoms from COVID and not necessarily pulmonary. And so he's got, fairly significant gastroenteritis. And if we assume it's COVID, it's kind of, significant, but he doesn't have any respiratory symptoms and his FiO2 is pretty high. What would you do? Would you consider just monitoring COVID and treat the gastroenteritis? I mean, at this case, this is one that, as a clinician, you have to just feel yourself and see what you want to do because of the fact that, and being that he's in the hospital, there may be more of an option to treat him. But how do you treat him? Well, Paxlovid, you got to give it orally. And if he's already having nausea, vomiting, he can absorb Paxlovid effectively. And so that would probably not be an option for him. The different monoclonal antibodies, please do not use the sotrovimab or the bebtelovimab. They're not effective against FBB or XBB. And convalescent plasma has been proven. But this might be the perfect case to use IV remdesivir. He already has an IV getting hydration, and you could simply add some remdesivir for 3 days and let it go. So this would be a case where IV remdesivir may trump the other the other answers here. And so in the answers here, monitor COVID and treat gastroenteritis. Definitely, that would definitely be not an incorrect answer because you don't have somebody other than the gastrointestinal symptoms, which you can be sure is COVID. I'm just saying that COVID can cause it. You could simply monitor him and see, and as long as he's not developing any respiratory problems, the FiO2s are going down or anything, go that way because he doesn't, his comorbid conditions aren't that serious and he's a younger guy. So I definitely would not disagree with that. The other option might be IV remdesivir if you decided to treat. Next slide. Case number 4. A 30-year-old calls you regarding recent exposure to COVID. He tested positive at home, and today has a scratchy throat, nasal congestion, and no other symptoms. He is otherwise healthy and has no past medical history. He had 2 COVID vaccine doses plus a booster 5 months later. What is your advice to him? So we've got a young individual, absolutely no comorbid conditions. His symptoms are very mild. And so he really has, very, very mild symptoms. So what would you advise here? Well, quarantine 5 days. And if afterwards he has no symptoms, he's not febrile for 24 hours, then you can let him go out and wear a mask for an additional 5 days. Or would you use Paxlovid or one of the other drugs? The correct answer here would be A. And I know most of us get a little nervous with COVID and we want to treat everybody, but this gentleman doesn't need treatment. He doesn't need to be put on any of the antivirals because he doesn't show any high risk capabilities for there. So just simply quarantining him and then properly and then monitoring him and letting him go is perfectly fine. So the other, the correct answer I feel would be number A. Quarantine 5 days and afterwards wear a mask for an additional 5 days. And remember, no monoclonal antibodies. Okay, the final case, number 5. 65-year-old comes in for advice. He has chronic lymphocytic leukemia and has received Rituxan. So another very high-risk individual. He's got a chronic condition. Chronic lymphocytic leukemia attacks your B cells, and so it knocks down your antibodies anyway. So you're hypogammaglobulinemic. Plus, he's on Rituxan, which adds further insult to injury. He's feeling great. He wants to visit his daughter in California, and he wants to fly there. He's had 2 vaccines plus a 3rd booster 21 days after that, which is appropriate for an immunocompromised patient, and just received his 4th booster, which is the bivalent. He did have a COVID antibody test, and it was negative, though. Now, please do not do the COVID antibody test as a diagnostic means to say, oh, you're immune or you're not immune. He just happened to have one, but it's not a standard. They don't recommend it. So this case did do it, but it's not one of those standards. And don't go by that as being negative. Don't go by that as being, but the point is, it wouldn't surprise me if he didn't have a very good immunity to what he had given his past medical history. So what would you tell him to do? Well, do not visit his daughter. Visit her, but take Paxlovid. Well, Paxlovid is not for PrEP. It's for treating somebody already infected. So this would be out of the guidelines, out of the standard of care for Paxlovid. Take Evusheld infusion. Well, prior to Omicron, this would be the perfect example of where you would use a monoclonal antibody for prevention. So Evusheld would be the treatment of choice. This would be the perfect example of how you would use a PrEP, pre-exposure prophylaxis. And it's effective for 6 months. What's the problem, though, is the patient doesn't have, there's no, the new variants are not effective against Evusheld, so the CDC doesn't recommend it unless you're in an area of the country or somewhere where the prevalence of the new Omicron variant is low, 20% or something like that, where you want to take the risk for it. So that would be, take Sotrovimab infusion. No, it's not going to help. Take molnupiravir. Again, it's not indicated for PrEP. It's indicated after you've been exposed. So any of the antivirals. You have some clinicians, I'll tell you, they go off label and they may say, take the Paxlovid, just take it with you. Take it, prophylactic. There's no data to support. They never did studies on pre-exposure, but you'll have some providers that'll do this if the individual really, really wants to go to visit his daughter, because this guy is at high risk for getting COVID. You're going to want to watch him, but at the least you want to give him Paxlovid as far as a prescription just in case he starts getting symptoms, and then have him test himself right away. And if he's positive, he's got the drug right there. He doesn't have to go to ER or anywhere. He can just get it and start taking it immediately. So that would maybe be the safest thing to do at this point. But Evusheld does not work. So unfortunately, that is not a good answer. So probably maybe A would be, if you could talk him into that and doing some virtual with him and hoping new monoclonals come out that are going to be effective. Or if he's really depressed and really wants to go in this and that, I mean, you could see what the incidence of COVID is in your area, but the new XBB variant is spreading like wildfire. Or just give him a script for Paxlovid, let him go with the script. And then if he starts getting any symptoms, scratchy throat, anything, test right away, test and treat, test and treat, test and treat. So that would be the next phase you'd want to do, but not to take it prophylactically because it's not indicated, none of the antivirals. So with that, we've ended a little early today, but I wanted to give you a really nice overview of the outpatient treatment of COVID-19 and what is being utilized. And hopefully this was a good overview for you for the primary care as far as how to treat different situations and what we have available. We have the antivirals, Paxlovid, remdesivir, and the new oral remdesivir is already in studies in the community. So it may not be long before that's released. So be cognizant of that. No drug-drug interactions with that drug. Molnupiravir should only be used when you can't use the other two because it only has a 30% response. And as of February 15th, we have no monoclonal antibodies to treat COVID-19 subvariants, Omicron. Thank you very much.
Thank you, Peter, for being here. And if you guys have any questions, please feel free. We got a couple minutes.
Yeah, we do.
If you want to ask
Any questions at all?
That was I enjoyed, getting people's answers and, the cases and stuff. So
yeah, that was good that you were able to do
Yeah,
that.
yeah.
Man, we'll have to do that more often then.
Yeah.
I'll have to get more cases in that because that was really very good, good to do.
I know there was a couple of you that asked specifically for some updates for COVID. So if you,
Yeah, this was the one I wanted to give because most primary care individuals are going to deal with this kind of a COVID, not the hospitalization ones, because they're, they're hospitalists and, I don't deal with it. So, but I deal with outpatients. So I thought this would be a really good talk for you on update on COVID, especially with the drugs being available and the new variants. I wanted to give you an update about don't use the monoclonal antibodies, not yet anyway, not until new ones come out.
and then the other thing is if there is any other topics that you guys want, please feel free to send them my way and we can look at incorporating them throughout the year.
Yeah, I know early on there was topics on tick-borne illnesses, and believe it or not, we're going to be doing that, right, Renee, in a different
Yes.
setting, but we're going to be doing those talks too. So I'll be doing the tick-borne things in the next couple months.
Yes, and that's a good plug here.
Mhm.
We do have another echo. It's called a One Health Echo on February 28th. At the same time, noon, lunchtime. So if you guys need the link, in your follow-up email, I will also email out that.
But like Renee says, this is your time and your conference. So let me know what you'd like to hear about, and then I'll try to provide whatever I can, as far as things like that. I may start to do the Hep C stuff again because the state of Michigan is really pushing for, trying to get more and more Hep C being diagnosed and treated. So I may give you a summary of that again, just to get you guys on that and give you a couple cases there too, that to get you comfortable with it.
Sounds good. All right. Well,
All
thanks
right.
again, Peter. And
Okay.
I will give you guys a follow-up email for your CME and have this presentation uploaded. So
Okay.
we will see you hopefully either on the 28th or next month I'm assuming it's March 15th too, because it's usually the same.
Yeah, second week.
Yep. All right, well, have a good rest of your afternoon and we'll see you soon.
Take care.
Bye-bye.